So our next speaker is Dr. Kristin Barignano. So Kristin is an associate professor of clinical neurology at Johns Hopkins University in Baltimore, and her research includes collaborative efforts with the Johns Hopkins Department of Genetic Medicine and the Division of Neurogenetics at the Kennedy Krieger Institute, um, which is how I met Kristin because my son is a patient of hers in Kennedy Krieger. Kristin specializes in the diagnosis and management of rare neurogenetic disorders. She has a particular interest in the genetic control and function of the cerebellum, and expertise in childhood onset and inherited ataxias. Kristin earned her MD and PhD from the Johns Hopkins University School of Medicine, where she also completed residencies in pediatrics and neurology, along with a fellowship in neurogenetics at the Kennedy Krieger Institute. And I'll never forget our first meeting because we had heard nothing from our genetics teams for years. For 5 years, we had had the diagnosis and heard nothing about research news. And she was not only prepared for all my questions at that meeting, but she told me the good news that she had pulled an IRB number specifically to study Jamuar syndrome in patient families. It was a breath of fresh air. So, Kristin, thank you so much for speaking today, and let's hear from Kristin now.
Well, thank you so much. Let me just share my screen here. So today I'm going to be speaking about some of the clinical features and clinical challenges in this ultra rare disorder. And so, as a child neurologist and a clinical neurogeneticist, it's been a super exciting time to have so many new neurogenetic disorders discovered. Being able to really provide families with a diagnosis to understand why their kids have these kinds of neurologic symptoms. But, having a name is just the first step, so we can parse over these scientific publications, say, okay, we've got a name, but what does this mean for our kids and how do we take care of them? And so with some of these rare disorders, there are just a handful of kids reported in the literature. And so the question is, how are we going to take the next steps forward in terms of understanding how to take care of our kids and then also move the needle forward on, therapies for them. So, after meeting with Rebecca and Thad, we talked about doing a project, which I was assisted with by an undergraduate named Rebecca Schulenberger. And so we decided what we would do is invite families to join us in structured clinical interviews to really get more granular information about some of the multi-system issues experienced by children with Jamuar syndrome. And so, when we, look through the initial publication from 2020, there's lots of descriptions about all the neurologic symptoms, but not much about some of the other systems that are involved as well. So this study was approved by the Johns Hopkins Institutional Review Board. And we were able to complete interviews with 5 families. And so there were a lot of logistical challenges just in the fact that it is such a very rare disorder. And it's worldwide with complications of language and time zone changes. But so we were able to include information for 5 families. So of those 5 families we interviewed, the ages range from 16 months for Connor, who we just heard about, to 15 years. Just randomly, 4 out of the 5 were boys. And I think that was just more a random sampling. When we look at the variants for the individuals that we met with, this is a schematic from the original 2020 publication. There's only 1 of the 5 who were included in this publication, so not surprisingly, their variants are circled. But for 3 of the 5, their variants had already been reported in the original publication. So there was 1 individual who had two newly reported variants. And this highlights the issue that with such a rare disorder that on these genetic testing reports, these are variants that are reported out as variants of uncertain significance. And so it really is the role of the clinician to put together the, bioinformatics of how the variant affects the protein with whether the clinical picture fits with the Jamuar syndrome. And so for all five of these individuals, really fit under the spectrum of what we think of developmental and epileptic encephalopathies. So, in terms of the very common neurological symptoms that we saw for all of these individuals, um, families were first concerned about their kids anywhere from birth to about 6 months of age when it was very apparent that there was something going on, that these were babies who had very low tone, they had trouble feeding, they had quickly apparent that they had lags in their development. For four out of the five, seizures were very early onset. For them, they were a type of seizure called infantile spasms, and so it's very typical that infantile spasms present around 6 months of age. It's like there's a window where the brain can produce this type of seizure, but it's very common for some of these genetic developmental and epileptic encephalopathies that they can present even earlier. In this case, 3 months. And then there was one child who started having seizures with fever at 13 months of age and then went on to have seizures without fever. Uniformly, these are children who have very profound developmental issues. We recognize that there's always a range of severity with these disorders, but this set of five children, none of them were able to sit without support, and all of them are nonverbal with very profound cognitive impairments with what we would call intellectual disability, so severe intellectual disability. And in terms of their seizures, their epilepsy, it's what we would describe as pharmacoresistant. So these are families that have cycled through trials of too numerous to count anti-seizure medications without necessarily making an impact on the frequency of the seizures, and then also experiencing the side effects that can come along with these medications. It's very typical for our kids with intractable epilepsy that we trial them on the ketogenic diet. And so some of these families felt like they got some benefit, but it wasn't necessarily a particularly robust benefit as compared to other DEEs. And two out of the five had surgical placement of a vagus nerve stimulator. It's also very common to report vision issues, something called cortical visual impairment, where the brain has difficulty processing visual input, and then issues with alignment of the eyes, what we call strabismus. So, in terms of where the UGDH gene is expressed and where the protein is made, we know that it is expressed throughout the central nervous system. This is something from a website called proteinatlas.org. So we know that it's important and widespread throughout the brain. But then it raises the issue of, well, where else in the body is the UGDH protein expressed and important? And so when we look at the rest of the body, we find that in all the other organ systems, we find expression as well. And so when we look at multi-system involvement, we, ask ourselves the question, is this because of other nervous system effects, or is it other systems are affected? And so it's important to think about the nervous system outside of the central nervous system when we think about all these effects, because we have also what we call, for example, the enteric nervous system, which are those neurons that control things like gut motility. So when people have feeding issues and constipation and reflux, is it because it's the dysfunction of the enteric nervous system? When we have trouble with coordinating our suck and our swallow, is it because it's neurologically mediated there, or is it more in the GI system? And so we know that that individuals with UGDH, with Jamuar syndrome, can have some subtle craniofacial differences in terms of minor differences in their physical appearance. And that probably relates to the differences in patterning that happen with the patterning processes that are happening that are dependent on the extracellular matrix early in development. But in terms of the symptoms that we start to see outside the central nervous system, all five of the children required gastrostomy tube placement to be able to feed safely, just weren't able to coordinate their swallow to avoid aspiration. Two out of the five have required a tracheostomy for them to have a stable respiratory status. And orthopedic complications are super common, including what we call neuromuscular scoliosis, spasticity, so the tightness in the arms and the legs that leads to that diagnosis is cerebral palsy. Some are reporting actually contractures related to that tightness, and hip dysplasia is a common issue in terms of children not being able to weight bear, and that becomes an issue in terms of positioning and comfort. Genitourinary issues are very common. Half of the boys had undescended testicles. Urinary retention and needing intermittent catheterization for that was reported. And there was at least one individual who's had kidney stones that may potentially have been a complication of a seizure medication. And there was one individual who reported premature puberty. So it's unclear if that's related to the endocrine glands themselves or the regulation of the pituitary and hypothalamic axis. So, as you can imagine, with so many systems involved for kids with Jamuar syndrome, it takes a village to take care of them. So, families are coordinating a very large care team with lots of different specialists that would include their pediatrician, their neurologist, or their epileptologist, sometimes a developmental pediatrician, their geneticist, physical medicine, rehabilitation, and orthopedics, a GI doctor, a pulmonary doctor, an ENT doctor, ophthalmology, urology, endocrinology, dentistry, and then all of their therapies that they're coordinating. So there's a tremendous intensity of taking care of these kids. And so it's, in terms of kind of opening up discussion to talk about this, it's super important to recognize these symptoms outside the central nervous system and how it impacts quality of life and the intensity of care needs. And going forward, there's something we're going to need to keep in mind the possibility of emerging phenotypes as therapies become a reality that are directed towards the central nervous system. We're going to change the natural history of this disorder. We're starting to see this with a more common condition called spinal muscular atrophy, where gene therapy is available. And with SMA, we've always historically thought of this as being a motor neuron disease. But now that these kids are surviving longer because of their, gene therapies and ASO therapies, we're starting to see more neurodevelopmental issues actually are a feature of SMA. But in terms of some of the ongoing challenges for us to be mindful of, we're challenged by the ultra rare nature of the disorder and language barriers and bringing families together. And with, kids who have such a high intensity of caregiving needs, it's sometimes difficult for families to have the bandwidth to think beyond the day to day of caring for their kids. We need to continue to work on variant curation so that we can be confident in offering therapies to when we're confident that a child has Jamuar syndrome. And we're going to need ongoing granular natural history data. It's not enough just to know that somebody has GI symptoms. We have to understand what those GI symptoms are. But then, one of the big picture issues that we need to be mindful of is what kind of clinical outcomes are we going to be selecting for these trials as these therapies become a reality? And so, especially when kids are so profoundly affected with neurodevelopmental issues, we need to think about finding endpoints for our clinical trials where we can see meaningful changes. And that's going to require family and caregiver input into what are going to be meaningful changes in functional abilities. So, for a child, for example, who's not able to sit without support, it's not necessarily going to be a reality that a therapy is going to result in them being able to run and climb stairs. So we need to think about what would be a meaningful change in, for example, motor abilities or communication abilities or self-care abilities. So those are some of my thoughts about what we need going forward, and I'd like to open up for discussion and thoughts going forward.
Wonderful. Thank you so much. Please feel free to put your questions in the chat or the Q&A box or unmute and ask your question. I'll start with a question. For rare disorders, it's very common that the most severe cases are identified first and the true range of a disease isn't known until the disease is more established. Do you anticipate that being the case here, where we'll start seeing more moderate to mildly affected individuals?
I think that's a safe assumption going forward, but we really, it's such an ultra rare disorder that that it, it is still we will find more mild cases, I'm sure. But even though this the initial publication in 2020, we just have not seen like a flood of diagnoses. So I think it's still going to stay a very rare disorder.
So that obviously presents some challenges with getting some of that granular data you were talking about. Um, are there, practical ways you've seen other groups like ours get over this challenge, or is it still actually something that groups like ours are needing to be very creative and strategic about?
I think being active and creative and strategic in terms of frequent outreach to families is super important in terms of just, helping families circle back to kind of the big picture in terms of, looking for the path forward to make meaningful changes and therapies for our kids.
Dr. Simpson asks in the chat, when you see other systems affected, do you think it is developmental or ongoing function issues?
So I think it's both. Especially when we think about the seizure phenotype and how profound the epilepsy is. I have a high degree of confidence that if we can improve the function of the UGDH gene, we can help even post-developmentally influence the function of the nervous system to help improve the epilepsy. So I don't think it's related just to the developmental footprint of those synapses initially being laid down.
We have another question in the chat. Did your observations involve only boys? Do girls also exhibit similar symptoms?
So there was only one girl who was included in the group, but her symptoms were very similar to all the other children's.
It's interesting that I remember you'd hoped to get more families involved in the study. You did get five, and it was limited to English speakers, and um, which I feel like, in a way, you've had a better success rate than our attempts to recruit for our survey-based study that we do with Combined Brain that is available in 8 translations, and it can be done from home and all of this stuff. So it is interesting that I feel relative to that, you actually did get a good response. And so I'm just kind of thinking aloud, like, I
Mhm.
think I think patient families respond better to a direct invitation from a clinician to kind of walk through like interviews and requests of specific information. I wonder if that's just more like just attractive than logging into some portal and answering a bunch of questions.
Yeah, so I think just a couple of comments there. So I am always just amazed by, families are actually really wonderful historians about their, diagnostic odyssey and the challenges that families don't always have the exact medical words, but they have an excellent understanding of what's been going on with their child and excellent recollection of what they've been through. And so I think some of it is having, it's one of those things that can be done at any time never get done. So I think having a scheduled date and time to meet with someone to talk about their child is super helpful. And also feeling, heard and having the opportunity to chat with a clinician about some of the challenges is also helpful.
And we have one final question in the chat. She asks what the age range of your patients were, and she mentions that her daughter is 6 years old.
So that would fall in the range. So the youngest was 16 months, and then the oldest is right now is 15.
How similar was your study to, we've heard recommendations to, get a disease concept study. There seems to be overlap with, the kind of questions you were asking. Um, what would there be significant difference?
So I think, going forward, um, I think thinking about Jamuar syndrome under the umbrella of a severe developmental epileptic encephalopathy, and kind of trying to align ourselves with the other severe DEEs is going to be fruitful in terms of thinking about things like clinical endpoints for studies and therapies. So, in terms of some of the literature that's out there, the people who are thinking about this, for example, with like SCN2A DE, is there's some really good literature out there that people are thinking about these issues. Of course, the children are all very unique, but in terms of how profoundly they're affected by the epilepsy and the neurodevelopmental issues, it's very similar to other really severe DEEs.